The types of endoperiolesions: lesions: primary endolesion, primary periolesion, primary perio with secondary endolesion, and true combined lesions. A primary endolesion, you will have a tooth that is non-vital. Inflammation may not be in apex. Inflammation may be in the foraca or lateral canal. Narrow, deep pocket. Treatment: root canal therapy. This is a way that you're gonna find if it's a primary endolesion. We'll have narrow, deep pockets because as soon as they found a way out, they don't need to make the way out any bigger. Now, a primary period lesion, it starts in the sulcus and moves to the apex of the tooth. You'll have a periodontal abscess, you'll have broad pocket formation, and the treatment will be a periodontal treatment, okay? Now, primary perio with secondary endolesion, deep pockets that reach an entrance to the pulp. Deep pockets: history of perio disease, possible past treatment. Treatment is root canal therapy followed by perio treatment. A true combined lesion, this is when perio and endolesion coalesce and are indistinguishable. We don't know who started first. It requires treatment of both endo and perio problems. The prognosis depends on how much of the periodontal component actually caused the destruction. Again, the prognosis depends on how much of the periodontal component actually caused the destruction. What are the objectives of a non-surgical endo treatment? The objectives of a non-surgical endo treatment are to alleviate and prevent symptoms. Well-sealed root canal therapy as close to apical constriction as possible. Debride and shape the root canal. Maintain and promote health of periradicular tissue. These are the objectives of a non-surgical endo treatment. Alleviate and prevent symptoms. Well-sealed root canal therapy as close to apical constriction as possible. Debride and shape the root canal. Maintain and promote health of periradicular tissue. What are the steps for non-surgical endodontic treatment? Axis, working length determination, cleaning and shaping, apical preparation, file dimension, irrigation, and obturation. Okay, how should the axis be? The axis should be in a straight line. This will reduce ledges or perforations, transportation and zipping, etc. Conservation of the tooth. Conservation of the tooth will help us reduce fractures. So conserve as much tissue, as much tooth tissue as possible. Unroofing the chamber to expose pulp horns. This will increase the visibility and help locate orifice. How should we establish the working length? Select a reference point stable and easy to visualize. Establish the working length. Okay. How can you establish the working length? With a diagnostic film using a 15 or a 10K file, estimate the length using paralleling technique. Using the apex locator, you can do it also by using an apex locator or feel the apical constriction. Now, feeling the apical constriction alone is not a reliable way. of establishing working length. How to clean and shape the canal. The best indication of how clean they are is how smooth they are. Best indication of how to clean, how clean they are is how smooth they are. You will gain a lot of benefit on cleaning and shaping the canal by pre-curving your files. Obtain taper canal to facilitate obturation. Now, how to obtain apical preparation? Apical stops help confine instruments, material, cement, and create a barrier that allows condensation of gutta percha. How to obtain apical preparation? Apical stops help confine instruments, material, cement, and create a barrier that allows condensation of gutta percha. Irrigation materials used in non-surgical endodontics: sodium hypochlorite at 0.1 to 1%, EDTA, which is ethyl diamine tetraacetic. EDTA is ethyl diamine tetraacetic, 17%, and calcium hydroxide. These are the irrigation materials used in non-surgical endodontics. Again, EDTA, ethyl diamine tetraacetic, 17%, and sodium hypochlorite at 0.5 to 1%, and calcium hydroxide. Calcium hydroxide characteristics: they disinfect, dissolves the organic matter, and does not remove smear layer. So EDTA does remove smear layer. So sodium hypochlorite characteristics: disinfects, dissolves organic matter, and does not remove smear layer. Sodium hypochlorite accidents: they will cause pain, bleeding, swelling, erythema, bruising.
Erythema.
Erythema and bruising. Okay? So, the treatment for a sodium hypochlorite accident: anesthesia, analgesics, steroids, drainage, and cold compress. Anesthesia, analgesics, steroids, drainage, and cold compress. EDTA characteristics: they remove inorganic materials and remove smear layer. EDTA is ethyl
Ethyl.
ethyl, not ethyl, it's ethyl
Diamine.
diamine, ethyl diamine,
Tetra. Acetic.
ethyl diamine, tetraacetic. EDTA removes inorganic material. The purpose of the obturation is to eliminate the leakage from the oral cavity or periradicular tissue into the root canal. Seal the canal to any irritant that could not be removed. Advantages of gutta percha: easy to manage, low toxicity, easy to manage, easy to remove, and self-sterile. Does not allow the growth of bacteria because it does have some in its ingredients. Silver is used. Also, very important here is that one of the advantages of the gutta percha is that they have uh, some salts, which I'm not remembering which kind of salts, but these are going to be radio opaque. Will give you radio opacity on your X-ray. The disadvantages: they need a sealer cement. They have no adhesion to dentin.
Adhesion.
No adhesion to dentin. Rebounds to dentin and shrinks after cooling. What are the surgical endodontic treatments? Surgical endodontic treatments, it is incision and drainage or trephination.
Trephination.
Trephination. Incision and drainage or trephination of the bone. Incision and drainage or trephination. No, trephination is not necessarily incision of the bone. Incision and drainage of or trephination, which is incision. Okay. Root and resection, which is an apicoectomy. Apicoectomy.
Apicoectomy.
Apicoectomy. Apicoectomy. Okay. Hemisection, bicuspidation, root resection, intentional replantation, and surgical removal of apical segment of fractured tooth. The objective of incision and drainage or trephination is to evacuate exudate, purulence, and toxic irritants to speed healing and reduce discomfort. Indications for incision and drainage: localizes fluctuant swelling. Indications for incision and drainage: localizes fluctuant swelling. Pain is caused by accumulation of exudates. Sample for bacteriological analysis. So, indications for incision and drainage: to localize the fluctuant swelling. Pain is caused by accumulation of exudates. Indications for trephination: hard tissue drainage needed. Pain caused by pressure by exudate within alveolar bone. Sample for bacteriological analysis. Trephination. Trephination pretty much means that you will make a hole with a burr. So, sample for bacteriological analysis: pain caused by pressure to exudate within alveolar bone. Hard tissue drainage needed. These are the indications when you're going to do a trephination. What are the characteristics of incisions? It should be made through periosteum, should be parallel to major blood vessels and nerves. Characteristics of incision. When should we indicate antibiotics when performing incision, drainage, or trephination? Only if diffuse swelling, cellulitis, only if systemic symptoms present, and only if patient is immune compromised. When should we indicate antibiotics when performing incision, drainage, and trephination? Indications for apicoectomy or root and resection. Persistent or enlarging periradicular pathosis. Indications for apicoectomy or root and resection. Persistent or enlarging periradicular pathosis. Overextension on sealing material. Biopsy. Access for root and preparation and filling. Apical and cannot be shaped, cleaned, or filled. These are the indications for apicoectomy. If the apical portion of the tooth cannot be accessed, cannot be cleaned, shaped, or filled. Okay? Biopsy and overextension on sealing material, or persistent or enlarging periradicular pathosis. Contraindications for apicoectomy or root resection. When are you not going to do an apicoectomy or root end resection? When there's anatomic factors involved, systemic complications, non-restorability, poor crown-root ratio. Okay, you have poor crown-root ratio, you will not do apicoectomy or root end resection. You have a tooth that is non-restorable, there's no need to do an apicoectomy. Or you have systemic complications like bleeding problems or some other problems, and anatomic factors. Types of flap design for an apicoectomy. Subgingival curved flap, which is a semilunar. Remember that for semilunar, for any other, you cannot do the actual resection of the flap when there is bony defects or protuberances. Okay? Submarginal triangular and rectangular flaps, and full mucoperiosteal flap. These are the types of design of flap for an apicoectomy. Disadvantages of a semilunar flap or submarginal curved flap is that there is restricted access with limited visibility. Leave the incision over the lesion. Will often heal with a scar. These are the disadvantages of semilunar flap or submarginal curved flap. Steps for root resection. What are the steps for root resection? Remove root tip during surgery. A 45-degree bevel is replaced with 0 to 20-degree bevel. Bye.
Fui.
No me avisaste que ya venías.
Baby, from the moment you know I'm out, that should